So now you learn what is COU, right? So you know what is COU? Context of use. Okay? So whatever we have been discussing so far about biomarkers, they have been about COU, context of use. You need to define the context of use. Does it make sense? Okay. Let's go to the next second question. What was NNS? Now I'm going to talk about NNS for 5 minutes, another 5 minutes, and I will wrap up the discussion that we had. The launch is going to be ready at 1:45. So you are just 20 minutes to the launch. So stay with me. We are going to get there. So what is NNS for MRI? And the impression that you had in terms of MRI is expensive, right? So I need to justify cost benefit of doing MRI. So NNS and cost benefit. Sounds good? So that's going to be the next section. Have you heard about NNT? Those who are from medicine. Do you remember what was NNT? We had that in statistics. When you run a trial, when you have a medication, they ask you, what is the NNT of that medication? What was that? Necessary number for, what was that? Okay. So, NNT is number needed to treat. What does it mean? Number needed to treat. Okay, what does it mean? For example, for SSRIs, you have heard about fluoxetine, right? Or sertraline, the things that we have been discussing about. What is the NNT for SSRIs for treatment of depression? What does it mean? It means that how many people you need to treat with an SSRI medication to have 1% responding to the medication. You know that everybody, and it's not the case that everybody is responding, right? A group of people are going to. And NNT is that number, okay? And specifically SSRI, do you know how many people you need to treat with SSRIs to have 1% responding or 1% going to remission, full remission of depression? Any estimate? Just a rough estimate. How many people you need to treat to have one full remission because of SSRI? 3. Okay, optimistic. I'm happy that you are very optimistic about us psychiatrists. So, yeah, looks like a good kind of client for the clinics. Hopefully, you're not going to be very frustrated after working with us for a few months. NNT for remission is something like 8 to 12. And for response, what is the difference between response and remission? Response means that your whatever depression that you have been experiencing would be half. If you experience half of the depression that you have been experiencing before, it's response. But if you have 0, then it's remission. Okay? So to have response, you need to treat at least 6 people. And to have remission, you need to treat at least 8 people. So the number is pretty high, right? But that is also the case for many other medications. Antihypertensive medication. Or in many other areas, it's just almost, 2, 3, 4, 5, it's kind of the number. ECT for depression, which is electroconvulsive therapy, okay, which is more effective in treating depression. The number is something like 2 to 3. So every 2 people that you treat with ECT, 1 of them, they go to remission. So which is pretty strong, right? So that is the goal. When nothing is working, ECT is the best thing that we use in the field of depression. And this, for TMS in the field of depression, the numbers is around something like 4 and 6. So you need to treat 4 people to have 1% responding and 6 to have remission. So these are the numbers. So this is what we call NNT. Okay. And what is NNS? NNS is number needed to scan. How many people you need to do to scan? All the types of imaging that you have to have 1% having different outcome. For example, in the field of breast cancer screening with mammography, how many people you need to do mammography to detect 1 breast cancer? Do you know the number? 1? How many people you need to screen to have 1 of them having cancer? 10? So every 10 people that they have mammography, 1 of them have cancer? Is it that bad? Hopefully not. Is around 1,000 to 2,000. So NNS for breast cancer detection is 1,000, okay? For preventing death, one cancer death is around 2,000. 2,000 mammography you do to just prevent one death. And you do it routinely, right? So that is something that is being used. For using mammography to change the treatment program for somebody who already has cancer, NNS is something like 50. It means that you need to do something like 10 to 50, depending on the type of cancer, that the mammography would change the way that you do the treatment, okay? So that is what we call NNS. It's a usual name in the field of radiology. And I can give you some numbers, other NNS in other areas. For example, NNS for prostate cancer, doing MRI for prostate cancer, for treatment of prostate cancer is 10 to 20. Cardiac imaging, like a kind of CT for coronary artery, it is something like a 25. Brain imaging for stroke is 5 to 10. So the best NNS number that we have in the field of brain image, in the field of imaging and brain imaging and MRI, things like that, is around 5. So the best number that you have is around 5. And then ultrasound for thyroid, 10. Vascular cardiac ultrasound, 10. So, and this is something that they have in the field. And the question is, if you want to do individualized TMS, it means that you need to do MRI first, and based on MRI, doing an individualized TMS. What is NNS for individualized TMS? For doing MRI to do individualized TMS based on MRI. And that's an important question, right? To be able to answer this question, we need to have studies that they show the effect size of doing individualized TMS compared to non-individualized TMS without MRI. How much adding MRI to doing TMS is increasing the effect size of TMS? Okay, does it make sense? Okay, you need to have this number. If individualized versus non-individualized can give you an effect size of around 0.3, NNS will be 5. So if you can have one study that shows that individualization of TMS is going to give you a moderate effect size, NNS is going to be 5, which is almost the best in the field of brain imaging. And if the effect size is something like a 0.8, 0.9, the NNS will be something like a 2. So we have been actively looking on all those individualized TMS studies, trying to find studies that they are comparing individualized versus non-individualized to see what is the effect size that they are reporting. There are already 34 trials up to July 2025 that they use fMRI to do individualized TMS. And they are in different areas, as you can imagine. Schizophrenia, stroke, depression is one of the major, OCD, different areas of the brain, numbers increasing. I mean, first half of 2025, we had 9 trials. So the field is just exploding over time. But from these 34 studies, 45 experiments, almost none of them comparing individualized versus non-individualized. Most of them, they are just comparing individualized versus sham intervention. Because that is an easier trial, right? So when you compare individualized versus sham, there is a higher chance that you can have a positive result. When you compare it with something that is already working, then the difference is lower, and your chance to find that difference is lower, okay? These are the studies that people are doing with different protocols, different areas. But there are something like 3 studies that they have done something, not in the best possible quality. One in schizophrenia, one in autism that is recently published, which is probably one of the good ones, June 2025. One that is still in preprint from one of our friends, Desmond Waters. Very nice study. The other one is from a trial from Harvard. It's called AIM trial. They have just one abstract from that trial. And I'm in touch. I just sent a message to Joe Taylor just 2 days ago. I was asking him when your preprint is going to be out. And he says, in 2-3 weeks. So the preprint is going to be out. But interestingly, their effect size is around something like 0.4. And if it is going to be the case, then the NNS is going to be around 5. okay? And then with NNS of 5, I can do a cost effectiveness analysis in terms of, does it make sense to spend money for MRI to do individualization? And I can do that. We don't have time to go to the details, but I can measure the dollars and I can show you how it is going to be cost effective. As it is cost effective to do MRI when you have a stroke. MRI is expensive, but when you have a stroke, it makes sense to have MRI. And it is true for brain stimulation and MRI-informed brain stimulation and individualized brain stimulation. So that is the hope that we have for the field. That targeting, individualized targeting biomarkers could be a part of the routine clinical practice in the field. And that is very critical.